Hello and welcome to this screencast related to our Patellofemoral workshop we have coming up in Melbourne on the 23rd of July. I'm very excited to have Professor Bill Vicenzino and from University of Queensland and also Dr. Michael Raffliff from Aalborg in Denmark coming over to visit us and hold a workshop which is going to be a highly practical one, and obviously alongside myself and Professor Kay Crosley. It should be a lot of fun and quite an entertaining and most importantly educational day. These podcasts or actual screencasts are designed so that we can focus primarily on practical application of the evidence on the day, but also so that we can share some of this information more widely around the world. So this is one of the free ones which will be on offer, and hopefully you guys will find it both enjoyable but also share it with many of your colleagues. It's also an initiative related to TREC, which is a group that we're beginning to set up around translational research, and the purpose of this is to try and improve our ability to get research findings out there into the real world and have them have an impact on clinical practice. So we're going to talk first of all about patellofemoral pain in terms of common deficits which we often see. Now, disclaimer is that I could talk to you guys for at least the next couple of hours around this, so we won't be covering every deficit, but we'll go through a lot more on the day at the workshop and more practically. I'm also happy to have discussions on Twitter and social media, etc., around some of the content that may be in here. So the first question I'd like to pose is, why are we here? Does patellofemoral pain actually matter? And if you haven't watched it already, I really strongly encourage you to watch Michael Raffliff's presentation, which is also available on the website here and wider social media around the impact of patellofemoral pain and how common it is. Next question we need to ask is, why does it hurt? So why is pain there in the first place? And I'll touch on this a little bit, and I think there's a lot of complexities here which we need to continue to explore with research. Some people believe that perhaps pain is just a perception in patellofemoral pain and that biomechanics may not matter. But what I want to talk to you guys about a little bit in this screencast is the fact that we probably need to consider all of these things together. And in fact, some of the biomechanics that we need to consider actually become far more of a problem once the condition develops rather than them being an issue in the cause of the condition. I think that's a really important point to make. So I won't go long into detail around the significance of patellofemoral pain because I think Michael's already done that very well. What I want to do is just make two very, very, really important points. And that is that we see nearly half of individuals with patellofemoral pain will actually cease their physical activity. So they'll stop playing the sports and doing the things that they enjoy, which has obviously a very detrimental effect on their quality of life. Most importantly though, it's also going to have potential detrimental effects on cardiovascular disease risk, on diabetes risk, and various other health conditions also. The other thing that we're starting to potentially see is that we may need to consider this condition of patellofemoral pain as a continuum related to osteoarthritis later in life. And this obviously has big implications for potential need for surgery down the track, but also, again, more detrimental effects on an individual's quality of life. So we need to consider the impact of it beyond the actual knee pain itself, and that's a really important point to make. Prognosis, this is you'll see Patellar, which is a common paracetamol tablet, which is used here in Australia. And this is a common thing that people get told when they present to their general practitioner, is that they get told to go home, take some paracetamol or take some NSAIDs, and their pain should improve. But in fact, what we do know is that when we look at a number of different studies, that we see between 70 and 90% of people diagnosed with patellofemoral pain will continue to experience recurring pain up to 20 years following their diagnosis. And this is based on the research we have. So it's really important that we consider far more than just the pain. We need to have a consideration around, well, what has the pain influenced and what are some of the deficits that might develop that we maybe need to address in the longer term? Or is it just educating the patient around just simple activity modification and being sensible with their training loads, etc.? So we also know that longer symptom duration and greater pain severity is linked to poorer rehabilitation outcomes. So one of the key things that we need to try and do collectively when we're trying to manage patellofemoral pain is, ideally, we try and treat these patients early and we treat them very well. And a lot of this comes down to education, which we'll talk a little bit about in an additional screencast, but also we'll talk a lot about on the workshop during the day. So we have this significant problem, and we know that it's not a self-limiting condition, and that's something really, really important. The question is, what do we do about it, and why does it hurt? So the source of symptoms in patellofemoral pain is a highly debated issue, both internationally, amongst researchers, on social media, and we really lack a consensus as to exactly why someone with anterior knee pain or patellofemoral pain actually has their pain. Now, we have a consensus meeting every 2 years around patellofemoral pain. We get usually around 50 people who are doing very high quality research in this area, and we struggle to come to consensus. So we don't know whether the source of the symptoms relates to articular cartilage, the synovium, possibly the fat pad, various other structures around the anterior knee. What we do know is the pain is there, it's real, and it's significant. So some of the biomechanical theories relate to an increase in patellofemoral joint stress. So if we look at some modelling done by Firoki and their group in the States, and this is not insignificant research, so you'll see numbers of 10 in each group in a control and also in the patellofemoral pain group, it tells us that we have an increase in lateral patellofemoral joint stress. So what we see this during a simulated squatting task, both at 15 degrees and also 45 degrees of knee flexion. So we can see very clearly on the graph that in a control population around 45 we have an even distribution. In the group with patellofemoral pain we have this more laterally directed increase in patellofemoral joint stress. So this is indicating there's possibly some form of patellar maltracking that may be occurring. And what it means is that even under potentially lower overall load of our patellofemoral joint, we possibly have a heightened stress looking at the patellofemoral joint itself and articular cartilage, which in theory may lead to joint degeneration and potential osteoarthritis down the track, and possibly one of the drivers of the symptoms. If we continue on the biomechanical theme, there's been a long-standing theory that patellofemoral pain relates to patellar maltracking, and when we think of patellar maltracking, what's really, really important is we don't just think about it unidimensionally. So patellar maltracking relates to an increase in lateral translation, where we actually get the patella that shifts laterally. We also see an increase in lateral patellar tilt, where it actually tilts laterally, and then an increase in lateral spin shown in some research, where the inferior pole actually shifts laterally also. There's a couple of important points about this, and that is that there is relatively clear evidence that has shown this to occur in individuals with patellofemoral pain on MRI findings, but particularly that the actual maltracking that does occur seems to happen towards terminal extension, and this is particularly in open chain tasks. So what this means is we may need to be very, very cautious of any quadriceps loading that we might do in an open chain moving towards terminal extension, and that's incredibly important. So we do see some biomechanical potential links, but again, it comes back to the point that we still don't know which of the tissues being stressed as a result of this necessarily. And then if we look to the more pain science side of things, we also need to consider sensitization. And Michael Raffliff, who will be at the workshop, did some great research in his female adolescents with patellofemoral pain. And what they looked at is pain pressure threshold testing. So how much force or how much pressure is required to stimulate a pain response. They looked at this both locally at the patellofemoral joint, but they also looked at it remote to the site, so looking at the tibialis anterior muscle. And what this shows us in adolescents or female adolescents with patellofemoral pain is they seem to have this hypersensitivity, or they seem to have a widespread hyperalgesia as a response to their condition. Now, we don't know whether this is a cause of the condition or whether this is an effect of having the condition. So when we look at adolescents with no pain, their threshold to pressure is much higher, both around and on the patella, and also much higher at the tibialis anterior. And those with patellofemoral pain, thresholds being much lower. So there's possibly something centrally going on in these individuals. More recently, I've been involved with a research group in Brazil, and Fazanato et al. We looked at, again, looking at the same concept around, is there a sensitization using this pain pressure threshold testing around the patellofemoral joint? But this time, instead of using a remote site distally, we used a remote site on the upper limb. So this time we actually used the contralateral and we used the shoulder. And when we look at this, what we find is that there seems to be an increase in sensitization at the shoulder also on the contralateral side. So possibly showing some really widespread hyperalgesia in people with patellofemoral pain. This time not in adolescents, but this time in female adults. So one of the interesting findings about this study is that, at least in acute exacerbation, so when we had these people with patellofemoral pain walk up and down stairs, we didn't see any increase in hyperalgesia as a result of that task. So they have an increase in pain, but the actual results around PPTs or pain pressure thresholds seem to be much more stable in the acute setting. Now what that means in the long term, we don't know. So it may be that sensitization increases with repetitive pain occurrences, but we don't know that and we need to look a little bit further. Now, regardless of whether it's related to central changes or pain perception changes, or if it's related to more of a biomechanical approach, what we seem to see is that patellofemoral pain occurs with a rapid increase in physical activity. Michael talks more about this on his screencast. So one of the things that are most important around prevention, and probably more important than anything else, is load management. So if we have a rapid increase in physical activity, we get an increase in stress on the patellofemoral joint, whether that's associated with maltracking or not. There's potential for pain, and as a result of that, what we tend to see is people will stop their physical activity, and they stop doing anything till their pain goes away. They rapidly increase again, their pain comes back, so they stop their physical activity, and their pain goes away, and they go through this cycle. And eventually what happens is they do exactly what we talked about before. Half of people with patellofemoral pain is they stop actually completing any physical activity. So what's really important around the prevention of this condition, and any musculoskeletal condition for that matter, is we educate our patients around this sensible increase to their activity management in terms of how much load they put through the joint. So we stay away from this strategy and we make sure we work towards this. Now that would be great if that was the only answer or only solution we required for patients with patellofemoral pain. But unfortunately, even when we follow this really well, when we have a patient presenting in front of us, we still see many of them will still complain of ongoing symptoms. So clearly there's a lot more for us to consider. So when I think about this, and this is something I look at with my patients in my clinic, is I always think about this vicious cycle that occurs. As a result of pain, and most often doing too much too soon, or in some cases possibly trauma, we develop maladaptive behaviours. So we start to develop things like kinesiophobia, we possibly avoid certain activities, or if we do continue to do activities, we change the way we move. So for example, we know people with patellofemoral pain will often walk and run with less knee flexion. When they walk, they may have more femoral external rotation. So all of these things can lead to deconditionings of muscles in terms of both strength and motor function, but also thinking about soft tissue flexibility. And as a result of this, we can get changes to our biomechanics, which can then increase stress on our patellofemoral joint, and that can lead to pain. And we possibly see pain processing coming into this as well, with consistent and persistent pain. So over time, we get this vicious cycle occurring, and it feeds on itself, and biomechanics may not have been an issue at the beginning, but as a result of the pain and this vicious cycle, it becomes far more problematic. Obviously, the longer this vicious cycle's been occurring, the more issues we may have to deal with in the clinic. So what I want to talk about now is, what does the literature tell us around functional and modifiable deficits? So what can we identify that we might be able to change in these patients with patellofemoral pain? And we want to also think about differentiating risk factors from contributors. So is there anything else that might be a risk factor beyond just doing too much too soon? So I'll talk a little bit about structure, and I'm not going to go in depth into this. This is the only slide related to structure. And the reason I'm going to talk about it is because commonly there's been a few widely held beliefs that structure has a big influence on patellofemoral pain, especially within the surgical literature. So some of the common things that get considered is an increase in Q angle. So that is the angle of the thigh relative to the tibia, and thinking of this statically more commonly, especially in the surgical literature. And what the research evidence tells us is that actually it doesn't seem to be a risk factor for developing pain, and probably isn't associated with pain either. Associated with this can be wider pelvis, and this is something we see more so in females. But again, we don't have any evidence to suggest that this increases our risk of developing a condition like patellofemoral pain. We can also think about femoral anteversion or structural internal rotation of the femur. So these are the patients we see with those inwardly pointing patellas. And again, we don't have the research evidence out there to show us that we are more likely to develop patellofemoral pain. Now, I've seen many people functioning without any patellofemoral issues or lower limb issues for that matter, with very structurally internally rotated femurs. So I'm not sure that it's a strong link around injury risk. And then the final thing is a shallow trochlea. So we know that the shallower the trochlea is, there's less congruence of the patellofemoral joint, and therefore we possibly get a bit more patellofemoral instability, and this can be linked to pain somewhat. But this is not something that we can change, and in fact a lot of the surgical interventions that occur to try and improve the trochlear groove or try and improve the depth of it, they sometimes help with our patellar instability, but in fact what happens is they lead to more patellofemoral pain because it's not actually changing potential compressive forces, and it can actually increase these. So what I want to move on to more so is, well, what can we change as physiotherapists or as allied health practitioners who might be managing these patients conservatively? So the first question is VMO important? So this has been a long-standing belief that VMO is one of the cornerstones of rehabilitation around patellofemoral pain. And it's interesting, and this was a search that I did a little over a year ago now, and what I did is I just typed VMO into PubMed just to see what would come up, and we get 305 papers, and I think this would possibly be well over that now, possibly pushing towards 400 papers. So clearly there's a lot of research interest and a lot of research endeavours that go into looking at VMO. But when we look at the literature, it's quite interesting. Firstly, what we do see is that VMO relative to vastus lateralis appears to be delayed during tasks like stair ascent and stair descent. And this is a nice systematic review done by Chester, which is now a little bit older, but still gives a nice summary of where the evidence is at. But the important point that Chester makes is that there's marked individual variability in both people with patellofemoral pain and healthy controls from this literature. And what that means is people with patellofemoral pain will sometimes have a delay and sometimes they won't. People without pain will sometimes have a delay and sometimes won't. And this can actually be individual variability just on the task as well. So one instance, someone with patellofemoral pain has a delay walking downstairs, and the next instant they don't. So it's really quite variable. The other important point is when we look at interventions like taping and exercise rehabilitation, where there's no emphasis on trying to recruit VMO or change this onset timing, what we see is that actually reversal of delays when we have a successful intervention. So it's possibly thinking that this is maybe more related to pain being present rather than it being a risk factor. But let's have a look at that a little bit more closely. Erik Whitvrow's group in Denmark did a really nice study looking at military recruits, and what they did is they did a rocking back task, and they looked at the VMO onset in a group who was about to start basic military training. 26 of the 79 who went through the study developed patellofemoral pain, so quite a high incidence of 31%. And what they reported was a significant delay in VMO activation in the group who went on to develop pain compared to the healthy control group. To put this in context, we're looking at around about a 6 millisecond difference between the two groups as an average. So 6 milliseconds is quite a small difference, and whether you can detect that clinically is a very good question. What important finding for me from this study was that after the basic military training, the group with patellofemoral pain now has a delay pushing closer to 20 milliseconds when compared to healthy controls. So there's a very small difference which is statistically significant, but maybe not clinically significant before basic military training. After basic military training, when they've got a group of patients with patellofemoral pain now, we see that this delay is much greater and possibly more clinically relevant. The graph shows this really, really well, and this shows the individual variability also that we see in many other studies. So we see before the study, in fact, 20% of individuals who didn't develop pain actually had a delay in their VMO activation. In the group who did develop pain, we have more than 40% who don't actually have a delay. So having a delay or not having a delay is not a sentence as to whether you will develop patellofemoral pain or not. Interestingly, all of their participants after the completion of the study actually had a delay in their VMO activation. So very clearly, in the presence of pain, VMO or medial quadriceps muscle function seems to be impaired, but whether it's a risk factor or not, or whether it's a significant risk factor or not, is a questionable issue. So really well designed study again by Erik Whitvrow's group in Belgium. This time they looked at muscle atrophy, and they wanted to see whether there was muscle atrophy in a group of people with patellofemoral pain compared to controls. So at the risk of silence on a screencast, I'm going to put the quote up from their conclusion. I'm going to let you guys read this for a second. So if we read their conclusion, very clearly that there seems to be an atrophy of VMO. Now, that's not surprising, potentially considering much of the research around this and perhaps the implication that VMO is impaired in terms of its function. What's not mentioned in their conclusion is whether or not any of the other musculature of the quadriceps has any muscle atrophy. So if we have a look more closely at the study, what we see is that yes, VMO is atrophied, but we also see equally that atrophy occurs in vastus lateralis and rectus femoris. So the point I want to make here is we need to be really careful around just attributing VMO and its function to patellofemoral pain. If we're doing rehabilitation, we may need to consider muscle balance of the quadriceps, but most importantly, when we're doing strength work, we need to really consider the muscles or the quadriceps muscle as a whole. So what about quadriceps strength in general? We see that reduction in knee extension strength or quadriceps strength is a risk factor for patellofemoral pain, particularly in military recruits. And we also see that reduced knee extension strength is occurring in those with patellofemoral pain, and this is supported across multiple cross-sectional studies. So certainly quadriceps strength seems to be an important factor related to patellofemoral pain. The question with this is it due to muscle atrophy, which there's possibly some link with that when we consider the MRI findings we've already talked about, but some of it may also be related to pain inhibition, and possibly if we reduce some of that pain inhibition, we may have a significant improvement in muscle function of the quadriceps and therefore strength and power capacity. But we certainly do get some atrophy and we certainly do get some weakness. So the question is, well, what causes this weakness? I've talked about the vicious cycle already. If we go to some of the literature, we certainly know that individuals with patellofemoral pain seem to possess this fear avoidance or kinesiophobia. And we'll have a couple of studies which show us that, and there's more research occurring at the moment. We also see from biomechanical studies that possibly as a result of this fear avoidance and kinesiophobia, that individuals with patellofemoral pain will reduce the amount of knee flexion they get during walking and stand negotiation and running. And as a result of this, they get less patellofemoral joint loading. So this is obviously a compensatory effect to try and reduce stress on the joint and therefore pain. But at the same time, this is possibly a reason why they develop deconditioning and muscle atrophy as a result. So I'm going to put a video of a patient of mine with patellofemoral pain. So she has left-sided symptoms. And if we look at her running, we can see a number of other factors or variables that from a biomechanical standpoint are often implicated in patellofemoral pain. So we see a contralateral pelvic drop on the left-hand side and the right-hand side for that matter, which will put more stress through our lateral structures and ITB, which in theory can cause lateral patellofemoral joint tracking. We see some internal rotation and adduction of the femur. We see excessive rear foot eversion, and those who are very interested in running will also pick up from the bottom view that we see quite a big overstride and a lot of anterior pelvic tilt. And we'll talk more about this through the course when we go to movement pattern retraining. But very clearly, in many patients, if we're focusing on addressing biomechanical factors, we can't be quad-centric. And this was a traditional approach in a knee-focused exercise, and we'll talk more about the evidence around exercise in another screencast, but we need to move well beyond quadriceps. So let's talk a little bit about the hip, again, going back to functional and modifiable deficits, so not thinking structure, and also thinking about risk factors and contributors. So Chris Powers' group and Rich Souza did a really nice study in 2010 where they did a weight-bearing study or weight-bearing MRI where they simulated a squatting task. And what they wanted to look at is what's causing this patellar maltracking that may be occurring in individuals with patellofemoral pain. So in their study, when they looked at the patella relative to the femur, they could see that they had lateral patellar displacement in the group with patellofemoral pain and lateral patellar tilt, which become greater towards terminal extension. And what they wanted to see is it the patella moving in space or is it the femur moving in space? And their findings are very interesting in that during a weight-bearing squatting task, they see no difference between a group with patellofemoral pain and a control group of femoral motion relative to space. But when they look at femoral motion, so patellar motion relative to space, when they look at femoral motion, what they see is that the femur has greater femoral internal rotation. So the driver of the patellar maltracking in this cohort anyway is related to the femur rolling underneath the patella. And the thing I talk to my patients about is the train and the tracks, and the patella being the train, femur being the tracks. So in this case, it's the femur or the tracks coming underneath the train. What's interesting, in previous research, the same group actually showed that the opposite occurs in non-weight bearing. So during something like a resisted leg extension, you actually see that the patellar moves relative to space rather than the femur. So this has important implications for our rehabilitation and shows us the importance that we need to address femoral motion, particularly in a weight-bearing condition or weight-bearing position in these people with patellofemoral pain at some point. So what about more functional tasks and what about things that often cause people to have pain like running? So, and is it a risk factor also? So Brian Noren did a really nice study where they recruited 400 female runners, all rear foot runners. They did 3D motion analysis on each of those. So those who know how to do 3D motion analysis will know that that's a significant amount of data collection. Out of 38 that reported anterior knee pain, they managed to get 15 back to their laboratory and diagnose them with patellofemoral pain. They matched them for age and monthly mileage, and then they had a look to see were there any kinematics that might be a risk factor for developing patellofemoral pain in this group. What they found is that the group who had patellofemoral pain had about 4 degrees more hip adduction than the control group. So this shows us that excessive hip adduction, or again thinking about the tracks moving under the train, may be a risk factor for developing patellofemoral pain in female runners. So importantly, maybe not just associated with the condition, but also potentially a risk factor. But we need to point out this is limited evidence, and we probably need to have this corroborated with further research. Michael Rathliff and I and others did a systematic review looking at hip strength, because this is something that commonly gets treated in the clinical practice, is thinking about hip strength when managing patellofemoral pain. And what we wanted to see is, does the evidence tell us that hip strength might be a risk factor for patellofemoral pain? Okay. So in our systematic review, we identified a number of studies looking at cross-sectional research where we had a group with pain and a group without pain, and the majority of them looked at isometric strength. We had very few studies looking at this as a risk factor prospectively, so very few studies measuring hip strength in a group without pain and then seeing who went on to develop pain. What the research tells us cross-sectionally is that when we look at isometric and eccentric hip abduction strength, and the findings are very similar also for external rotation strength, if we look to the left side of this graph, we can see that pretty much all of the studies show a trend or a significant difference in hip abduction strength, and similar for external rotation strength. So telling us that individuals with patellofemoral pain seem to have some weakness in their hips as a result of the condition. And as we said, external rotation similar, but a little bit less research and possibly not quite as strong in terms of the effect size. When we look at the prospective studies, there was really only one good quality prospective study, and this was a Start to Run program by a group in Belgium. And what they looked at is isometric strength for internal and external rotation, abduction and adduction, flexion and extension. And they also looked at ratios between some of these different tests. What they reported was that in their group who developed patellofemoral pain, there was no difference in their hip strength compared to the group who didn't. So it doesn't seem to be a risk factor for developing pain when we measure it isometrically. When we look at a couple of other studies combined with this in our meta-analysis, we see very much a discord between prospective and retrospective findings for hip strength, and that is that once people have patellofemoral pain, there seems to be weakness, but in terms of whether it's a risk factor for developing pain, it doesn't seem to be the case. So again, fitting with the fact that a lot of biomechanical variables probably aren't linked to a causation of the condition, but become a problem once the condition has developed. So it brings us back to this vicious cycle again. So why do people with patellofemoral pain tend to have weak hips? Most likely because of these maladaptive behaviours, kinesiophobia and altered movement patterns, which then leads to deconditioning. And this is something we need to keep going back to and considering. So if we look at neuromotor control, we talked about VMO delays already. We looked at a systematic review around gluteus medius function, one of the key external rotators and abductors of the hip. And what we found in groups with patellofemoral pain is during stair ascent and stair descent and running, there seems to be delay in the gluteus medius muscle activation. And similarly, there seems to be a shorter duration. So there's impaired neuromotor control of not only the quadriceps muscles, but also thinking about the gluteal musculature. What we don't know from current research is whether it's a cause or an effect of patellofemoral pain. Now, my own biased opinion is that most likely that it's probably not related to a causation, but again, possibly something that develops as a result of the condition being present. So, what about distal? I spent 3.5 years of my academic career researching this in the hope that we could provide a lot of answers, and I apologise, as part of this screencast I won't be able to do that. So when we think about the biomechanical relationship between the foot and patellofemoral pain, the theory is that if we get an increase in foot pronation, this will lead to coupling of an increase in tibial internal rotation. As a result of that, to maintain normal sagittal plane knee extension, we get an increase in femoral internal rotation, and this leads to our valgus collapse of the knee and an increase in lateral patellofemoral joint tracking, so the track's moving under the train. We know from research that prefabricated foot orthoses designed to control pronation are effective in the short term, and as part of the course, Professor Bill Vicenzino has presented some really nice screencasts related to the evidence and how to predict who may or may not benefit from foot orthoses, and there'll be a strong practical session around this on the day, which we look forward to, and I look forward to learning some more from Bill at the course in Melbourne. But what we don't know is what the link between patellofemoral pain and foot function is. So why might foot function lead to development of patellofemoral pain or contribute to ongoing pain? So if we have a look at some of the research, we did a systematic review around this recently, and when we look at dynamic foot function, we see a little bit of consistent findings around plantar pressure measures in patellofemoral pain during walking and during running, and that is that it shows us that there's possibly more of a lateral push-off both during walking and also during running. Now, we don't know exactly what this may mean, but my own biased thoughts are around this are that possibly it shows us that our foot is a little bit more mobile, and in particular, if we're pushing off more laterally, we won't get normal windlass mechanism function, so normal first ray function. And if that's occurring, we've got more instability at the foot, which therefore means possibly more instability at the knee, and therefore could lead to some increase in patellofemoral joint stress. But I must acknowledge that that's obviously drawing a long string, and we need to understand this a little bit better. If we look at the foot around static measures, or more so foot mobility measures, what we see is that increased navicular drop has been a risk factor, or reported to be a risk factor. The difference, though, very similar to VMO, is very, very, very small. So the difference here is around about 1 millimeter. So when we measure navicular height from a relaxed position compared to a subpatellar joint neutral position, we see a change of about 1 millimeter in those who develop, or 1 millimeter more in those who develop patellofemoral pain. So differences being around 9 compared to around 8. So whether that's clinically relevant or not is a very good question, and most likely we're probably not going to use this as a screening test for identifying those who might develop patellofemoral pain. What we do see though is we see an increase in foot mobility in people who do have pain, and some of these findings are actually a little bit larger, so possibly the foot may become more mobile as a result of the condition, but we don't have strong research to support that, and we tend to see a more pronated foot posture also. But again, it's not a strong link between them. The other important point about static foot posture, which is often used to prescribe foot orthoses, is that there's really not a great relationship between that and dynamic foot function. Bill will present a bit more research and a bit more practicalities around more foot mobility measures, and this possibly has stronger implications and has stronger use in clinical practice. If we look at the foot more dynamically and we look at 3D motion analysis, we did a study where we looked at walking in individuals with and without patellofemoral pain, and we modelled the foot looking at the rear foot, and we modelled the foot looking at the forefoot, so we could get an idea about movement throughout the entire foot, so we could compare rear foot to forefoot motion, rear foot to tibial motion, and also motion of those segments to the lab. Now this is a busy slide, and I don't make apologies for that because I just want to make one really important point. And that is when we looked at peak motion, forefoot relative to rear foot relative to lab, rear foot relative to tibia, so all of the common movement patterns we might expect to see being different if there was a true difference, we see that there's no significant difference for any of these measures in those with patellofemoral pain. The only significant finding that we had was during walking, and that was not an increase in femoral internal rotation, which we often see during running and other more dynamic tasks. We actually saw a reduction in femoral internal rotation. So possibly that kinesiophobia or maladaptive movement pattern to try and reduce stress on the patellofemoral joint, and as a result of that, that could possibly be one of the reasons that people with patellofemoral pain go on to develop hip weakness. When we look at running, which would possibly put a little bit more stress and be a little bit harder to compensate for, we see similar findings from Brian Noren's work, and that is that we don't seem to see any difference in rear foot or forefoot motion, but we do seem to see an increase in tibial internal rotation, and in the same study, Brian also showed greater hip adduction and internal rotation. So very clearly, we need to possibly rethink how we look at the foot, and one of my thoughts around this is that maybe it's not that we're trying to control always excessive motion, but we possibly are just trying to change the foot function a little bit, and as a result of changing foot function a little bit, that leads to a change in tibiofemoral function and patellofemoral joint function a little bit, and that's enough to change the stress on the joint and enough to change pain. The other, because we know that foot orthoses do work, and the key for us is to work out clinical measures that can help with that, and that's something Bill will present a lot on the day. The other point to make is probably the hip is more important. So we see much stronger links between hip function, both musculature and also kinematics, and patellofemoral pain. So I think some of our focus probably needs to stick more to the hip when we're first considering what we do from an exercise perspective, but it doesn't mean the foot may not be effective. So if we conclude common deficits around patellofemoral pain, we certainly see that there does appear to be patellar maltracking and an increase in patellofemoral joint stress. And we think about patellar maltracking, it's not unilateral or unidimensional. We need to think about lateral tilt, glide, and rotation. We need to consider quadriceps weakness and delayed VMO activation or muscle balance in the quadriceps, and they both seem to be related to the condition but also a risk factor. If we look at the hip, we see hip muscle function deficits like delays of gluteus medius muscle activation and impaired durations or shorter durations. We see an increase in hip adduction and internal rotation, which are possibly also risk factors, at least in females. And we see a loss of trunk and pelvic control, which we haven't gone through lots around the literature today, but we'll go through that very practically when we go through some exercise rehabilitation as part of the course. And then finally, we see an increase in foot mobility when we're considering biomechanics. So we see that possibly the foot's more mobile, both from a structural standpoint, but also a dynamic standpoint. And importantly, we can't forget about the way in which the brain perceives pain and the way in which the body possibly becomes sensitized as a result of the pain. So we need to consider all of these things in our multifactorial condition, and we need to come up with a really multimodal approach or a combined intervention approach to address many of these factors. Our challenge clinically is everyone's going to have slightly different makeups of these deficits, so not everyone's going to have all deficits and not everyone's going to have the same deficits to the same extent. So what we need to do is try and tailor things as much as possible, which is what we hope to do as part of the workshop. So thanks for your attention today, and hopefully you've got a lot out of that, and hopefully we'll see some of you in Melbourne on the 23rd of July. Thanks very much.